Hello, and welcome to the Longev Lens. Please join my co-host, Dr. Sebastian Pedersen, and I as we cut through the noise and hype around longevity, health, and wellness, and turn the latest evidence into honest, practical insight for living better for longer.
And just a quick disclaimer before we dive in, this podcast is for educational purposes only and doesn't constitute medical advice. If you have a healthcare problem, please consult your doctor or qualified healthcare professional.
Welcome back to the Longev Lens, podcast number 3, where we'll be cutting through a lot of the hype and trends to do with cardiovascular disease. This one is, if you were to look at a lot of podcasts and a lot of media around the world, it's a really conflicting, really confusing topic that we need to really try to knuckle down, because for one, it's actually been the biggest killer of essentially all humans globally for at least 70 years that we're aware of, possibly even longer. And it's still number one. Some statistics for this I wanted to actually go through to start off with, because it is quite alarming that 2023 there was 19.8 million people died just in that year alone. Per day, that's close to 55,000 people. And in the time that we record this podcast, there's going to be 2,260 people die around the world, which is enormous amounts of numbers from that one thing. The other part, in Australia alone, there's going to be at least 46 people die from cardiovascular disease. And that's actually a massive improvement on what it was, which is quite alarming, I've found as well. So why has this become such a big killer over decades? And what is it that we're not doing enough of that we need to try to work on?
Thank you, Corey. I think big ones is obviously how lifestyle behaviours have changed over the last century. But one is also the advent of the cardiovascular disease, as we talked about last week, compared to hormones. Cardiovascular disease is silent. It's progressive, but it's entirely prevented, but you need diagnostics early and you need interventions and action early. And that's where I think we have a lot of room for improvement in terms of not only preventing, but also really addressing, aggressively managing cardiovascular disease as soon as it's evident that it's taken a stronghold, and then preventing that slow progressive decline. Because we've all heard the story, you mentioned statistics, we've all heard the young, fit, seemingly healthy male or woman who suddenly adopts from a heart attack. Yeah. Because it's silent, we can't see it. So it's something that we need to do better at from a medical profession, of educating people about how silent and sinister this condition is, but then we really have to also optimize lifestyle behaviors and aggressive medical management early.
So what is, let's just start from the top. So what is cardiovascular disease, and what does it encompass? Because it's not just like a blanket, or it's essentially an umbrella of multiple different
exactly
things.
Right. Umbrella term for some of the big conditions like heart disease, stroke, peripheral vascular disease, where the hallmark of the disease is atherosclerosis or plaque formation within the arteries, leading to clots, leading to lack of supply either to the heart, to the brain, or to other cells where up or downstream of where the clot occurs.
So what if people to come to you and they were concerned about their cardiovascular health, is there any particular symptoms that they'd come to you with that are quite a common thing?
Yeah, absolutely. So when I was back in the public and private health system working on the wards, I was always seeing very late stage diseases. So we have people coming in with angina or chest pain. They're coming in with either mini strokes or strokes, or they're coming in with lack of blood supply to their limbs or toes, needing amputation because there wasn't enough blood reaching the actual lower limbs. So that's the problem, where these symptoms only occur once it's too late. But I would love for more people to come, and we do see it now, earlier downstream, to say, hey, I've got significant family history. I've never been tested for any of these conditions. Am I at risk of cardiovascular disease, or is it already occurring in my body right now without me knowing?
Okay, so how does a heart attack actually happen? Because this is, again, one of the most common. I think 85% of those deaths of what the statistics we were just talking about come from heart attacks and strokes. So it's much more like the sudden death. So how are they actually happening? Yeah, so it all starts with, if you have an artery, it all starts with the inner lining of the artery wall, the endothelium. There's damage. So the endothelium is very sensitive. It's a very delicate cellular layer. And what happens is there's damage to the inside of the blood vessel wall, either through high blood pressure, smoking, elevated cholesterol,
And what that then leads is the damage on the inside of the blood vessel leads to some increase in permeability. What happens then
It
is
increases little holes. And,
it's exactly right.
Yeah,
Exactly right. And then you have the cholesterol particles going into the blood vessel wall. They then become oxidized. And the oxidation results in inflammation, which results in the recruitment of immune cells, which leads to more inflammation, more permeability, more cholesterol particles entering the blood vessel wall. What happens then is you start to form a plaque, which then eventually, as it expands, forms a fibrous cap on top. The plaque can then become unstable, and then the inside of the plaque can then rupture, and all of the contents of the plaque will then get exposed to the actual inside of the blood vessel. That then clots the artery, resulting in heart attack or stroke.
So you mentioned cholesterol a couple of times, sort of getting lodged into these little holes. Is that correct? So,
Correct.
So how much does cholesterol play a role in this? Is it to blame, or is it the thing that's sort of it's just a response to all the damage that's been done with the permeability of the endothelium? How does it actually have an effect on heart attacks and
so the more cholesterol, then as with anything, the more you have of it, the more cholesterol will be able to deposit into the actual artery wall, thus forming more plaque. The less cholesterol, less plaque formation. So that's where cholesterol is the high. That's why you always want to reduce your cholesterol, especially if you're at risk. Because I know that there is a lot of hype about your net cholesterol. Cholesterol is not necessarily the agent, but in terms of plaque formation, atherosclerosis, it is required to exacerbate and for the progression of atherosclerosis, which is why cholesterol is very important to be on top of early and very important, especially for the right people, to reduce the concentrations of.
So, okay, if we were to test it, what would sort of be the things that you want to test with types of cholesterols? Is there any specific tests that you've been doing more of that might give you a better idea of high ranges?
Cholesterol for me is just one, as we know. So cholesterol is one of the risk factors for cardiovascular disease. So to back it up a little bit, we have in terms of risk factors for cardiovascular disease, things we can change and things we can't change. The things we can't change is our age, we can't change our sex, and we can't change our genetics. So for those three things, it's always important for us to be aware of as we get older. We're at increased chance of having cardiovascular disease. If we're, depending on male and female, we have cardiovascular disease at different times and of different severity. And we can go into that.
Usually earlier, isn't it?
Correct.
Quite
Exactly
a bit
right. Exactly right. And we'll touch on that in a bit. And then, of course, genetics, which is very important. It's always important people know their family history, especially their first-degree relatives and second-degree relatives, so their parents, their siblings, their grandparents, to know, okay, well, what medical issues did they encounter, if they encountered any, what was it, and at what age? So the earlier you have something, the more significant it is in terms of a genetic or inherited risk for future generations.
How much does the genetics actually play a role here?
It's definitely a component, especially if you have conditions like familial hypercholesterolemia, if you have...
What's that?
It's a genetic predisposition to result in elevated levels of cholesterol. Either you're not taking cholesterol out of the bloodstream or you're absorbing too much, but it's just a genetic cause for elevated cholesterol, which really needs to be managed aggressively very early from a very young age. Otherwise, these people who have these genetic traits are at increased likelihood of getting cardiovascular disease at even through like younger than middle age.
How would you test that? Is that the lipoprotein A?
That's another genetic marker.
Okay.
But we're talking about genetics, and lipoprotein little a is also a genetic predetermined risk factor of cholesterol. It's independent of the actual ApoB, which we'll talk on, and LDL cholesterol concentrations as well. So I do test for genetics for altered cholesterol metabolism, but also lipoprotein little a as well, which is one of the genetic factors we need to for everyone to be aware of, so that because they're things they can't change. So it's important to be aware of things you can't change before you go on to the risk factors that you can change.
I'm sort of going a little bit off script here because I only saw it the other day. I don't know if it's just because I've been looking into it a lot more. But have you heard of these PCSK9
inhibitors?
No, It is. I think they were talking about it may change or help to change that lipoprotein marker. So in turn, can that actually help reduce? So people who have a genetic predisposition to higher levels of cholesterol, can that actually help to lower that risk a bit more?
PCSK9 inhibitors are probably the strongest medication you can use for cholesterol lowering at the moment. There are specific PBS criteria in terms of who can get on the PBS or who can be subsidised through the PBS for these medications. But there's a good subset of people who don't meet the criteria for PBS who these medications will still benefit significantly. A good example is someone who has familial hypercholesterolemia, but when you test for these genetic predispositions, only about 20 to 30% of genotypes of people with genetic cholesterol abnormalities, cholesterol metabolism abnormalities, aren't actually found on genetic tests.
Okay.
So if someone who comes to me with significantly elevated cholesterol, and then they have young children who are in their teens or 20s or 30s with the same levels of cholesterol, who you've done genetic testing for, who don't actually show up anything positive because they don't meet the 70 to 80% of genes that are known for these conditions, because they don't have a diagnosed genetic condition or genetic abnormality, they can't get on the PBS for this PCSK9 inhibitors. Or the other people who can get on PCSK9 inhibitors are if you have evidence of heart attack, stroke, peripheral vascular disease. So it's very much an end-stage rescue treatment rather than a preventative treatment. So for some of these people, even though it's not on the PBS, for them, it would still need, the discussion needs to be held between their doctor and them to say this would maybe still be the best treatment option for you, but there is a cost involved, which is about $300 a month.
Wow. Okay.
So it's much more expensive.
Pretty expensive, yeah.
Correct, than just a $30 a month. So it's 10 times the price of a normal medication that you'd pay for. But that's where I'm a big advocate that doctors need to be advisors. They need to be explaining to their patients all of the evidence-based treatment options and the best evidence treatment options, even though they're not necessarily subsidised through the PBS.
I guess that leads into something that, because we are talking about cholesterol, we're talking about cardiovascular disease as a whole. And when I had a look through the World Health Organization, like their definitions of cardiovascular disease, what it is, how to actually treat it, I'll read it out because it was really frustrating that they mentioned all of these first line defenses as being like, the problems actually being more so that it's a lack of physical activity and lack of like poor nutrition, that sort of stuff. So I'll read it out. So the most important behavioral risk factors of heart disease and stroke are unhealthy diet, physical inactivity, tobacco use, and harmful use of alcohol. The next parts that they went into to try to see how we can actually try to prevent that, they'd gone through patients with cardiovascular disease should have access to appropriate technology and medication. Basic medicines that should be available include aspirin, beta blockers, calcium channel blockers, angiotensin, and like it just goes on. It's all medications. In their own words, they've actually said physical inactivity and nutrition is the cause of it. But then their first line is saying, here's your medications. Like, what? What do you mean? Like, where is the actual physical activity component of this? Like, if it seems to be a first line of defense for it. That I don't know.
I would 100%. That's where I'd love to, because you mentioned before the genetics we need to be aware of. We need to be aware of our family history, but we really, if there's one thing I would recommend the listener or the viewer to take away from today is exactly what you just mentioned, is the modifiable risk factors. What you can do today to reduce your risk of cardiovascular disease, whether it be heart attack or whether it be stroke, exactly as you said, it's alcohol, it's tobacco, it's exercise, nutrition, sleep, stress, emotional well-being, but then also being aware of all the biomarkers. So it's the cholesterol, it's the inflammation, it's the omega-3. So it's all of the things you can change. And we really need everyone to be on top of every single behavior and every metric you need to be aware of, and also reduce or optimize to reduce your risk.
As again, I'm sort of running some rough numbers. If you did those things, that would probably get you about 80% of the result, wouldn't it?
Yes, correct. And I think that's important. You can't, even with optimized lifestyles and aggressive medical management, you will never be able to prevent these conditions 100%. But exactly as you said, about 80% is preventable and relatively straightforward too. It's not simple science. It's not rocket science. It's just really optimizing behaviors and doing simple medical management or medical optimization very effectively.
So let's touch on that. So if we were to go and monitor, like, what is good health, so what is some good things, some good markers that we want to see for really good cardiovascular health? What are the big pillars essentially?
Well, you can let's go into lifestyle first, I guess. So you really want to make sure that you're exercising appropriately. And that's, I mean, so it's both strength and resistance. You have to have both. You can't have one or the other.
Yeah, how
So
often?
It depends on the person, but I mean, if you can get 1 to 2 hours per day, I'm always saying for a lot of our clients, 1 hour per day is usually my go-to. I would always want more, but considering there are other commitments, their responsibilities, my target is always 1 hour a day, 7 days a week over a longer period of time. And then you split that between resistance and cardiovascular exercise.
Yeah, that was actually something I wanted to touch on too as well, because I found a study from, it was Ben Levine that did some bigger work with his clients, that he got some people to train 2 to 3 times a week, or he got some other people to train 4 to 5 times a week. And then the others were more like the elite trainers, where they were doing 6 to 7 and they were doing like quite high hours and that sort of stuff. When they were looking at their test was to see how well the heart is functioning, like the compliance of the heart, essentially how, I guess for a simpler term, the elasticity of it in a way, how much it's actually blood it's able to pump out and all that sort of stuff. They found that the people who did 2 to 3 sessions a week of just like a moderate level activity actually had no increases. Like they didn't change their heart or vascular health really in any way. The people who were doing 4 to 5 times a week, from a health perspective, they actually had really significant changes in those markers. And again, the elites, they sort of had a little bit more again, but it wasn't to a massive, it didn't just keep skyrocketing up. It sort of went 4 to 5 and then it plateaued or plateaued, but just the increase wasn't quite as high. So yeah, like you said, you'd like to see our clients be doing training like every day, essentially for 45 minutes, an hour. And sometimes it's just not all that possible for them. Is there ways that you'd think that people be able to make sure, if they've got 20, 30 minutes, what should they be focusing on in that?
Exactly. I mean, the limiting sitting and the exercise snacks are key for one. So if you have a big day in the office, every hour you go for a 2 to 3 minute walk, or even just a 1 minute walk, just to keep your body moving throughout the day. If you have 20 or 30 minutes, get a bit of exercise in, and it's cumulative. So if over the week you have a couple of days where you just have 20 or 30 minute sessions, whether it's resistance, awesome, whether it's stair climbing, whether it's a run, whether it's rowing, whether it's cycling, whatever it is, just towards the end of the week, as long as you get on average about 1 hour per day, that's key. So, and exactly as you said, as little as 5 to 10 minutes is beneficial. So it's just a matter of capitalizing on those smaller time gaps rather than always expecting, I only have 35 minutes, I may not exercise because I was wanting to do an hour. Getting in that half an hour, that 20 minutes is so much better than nothing at all. Yeah,
30 minutes is still awesome. Like I find I have to do that quite often, which if I was to go into that a little bit more, like my mindset would essentially be do 5 to 10 minutes of warm up, do 10 minutes where I smash out like a higher intensity. I might just do 1 minute on, 1 minute off in that 10 minutes, or I might do 30 seconds as hard as I possibly can. Then sort of resting-ish pace for a minute and a half, maybe 2 minutes. Again, just in the 10-minute block. And then rest and recover for the last, or just find like a moderate pace for the last 5 to 10 minutes.
Perfect. I love that.
So it's just, it doesn't have to be difficult. I think it just needs to have more effort, execution in there, because you look around often in gyms that I find a lot of people are just sort of coasting, or they're just doing the same thing over and over. It feels comfortable. They know what it is. It feels easy. But at the end of the day, you might actually not be getting the result that you're going in there to try to achieve.
Oh, that's exactly. And we've all seen that. People at the gym, you've been going to the gym with for the last 3 to 5 years, and they haven't changed. You don't necessarily see them doing anything that's hard or anything that's heavier. So it's a matter of, exactly as you said, making sure you're getting the right stimulus to adapt and improve your exercise metrics.
And I guess the other part of that, what's your thoughts on strength training for cardiovascular health as well?
It's very important, very important. And I do still believe in splitting it. What I mean by that is doing more resistance, like pure resistance training, and cardiovascular, rather than sort of sometimes I see a lot of people doing high intensity interval training, and they're sort of getting not quite a lot of resistance gains, not quite a lot of cardiovascular gains. It's sort of like halfway in between. Whereas if you have just one session and you're on holiday or something, you just want to get something done, brilliant. But you use that as a mixed bag of cardiovascular and resistance training is not the best way to go about it. It's better to split the types of training you're doing. But I do believe resistance training or strength training is very important.
I think sometimes people might find as well, if they're trying to do everything all at once. it can be too much. You do actually
Correct.
need to, if you were to do a high intensity session, the next day might just be a more simple session, or it might be
Correct.
a moderate intensity strength type of session, and then the next day might be again just elevating a little bit more.
Yep.
So sort of
Yep.
fluctuating,
Yeah, that's
because
exactly right.
we don't actually improve from the training. We improve more so from the recovery stimulus
exactly
that you
right.
allow your body to actually go home, sleep, eat well, do all those sort of things to actually get that benefit.
One question for me to you, though, is
Yeah.
a lot of the people who we see haven't done much exercise, or they're motivated and want to do more. How do you go about assessing their safety profile? Because obviously exercise has risks. So if someone has never been tested before from a cardiovascular perspective, how do you go about assessing someone in terms of risks of, I often hear about heart attacks or stroke during exercise?
It's a tricky one, because when I was working in clinic a lot more, a lot of the time I would see them down the track, and these people would have awesome intentions and motivation, and I'd applaud that. It's amazing, but they'd often come to see me because they built up so many different injuries or issues over that time. And this might be like a month, 4 to 6 weeks, 2 months after training. We don't often get to see, which is a massive concern, we don't actually get to see who are the people at risk of starting these types of training. So what we do at Longev has actually been perfect, because it takes away so much of that guesswork of, I really don't know how well this person is to be able to start a health program. I'd often get people coming to see me and they hadn't trained, or they'd done nothing, essentially nothing for 6 months. Or I remember one particular person, it had been at least 10 years, and they had the goals of going, I'm going to do the half marathon in 6 months. And you're like, are you serious? Like, it's again awesome. I applaud the motivation and everything, but there's so much more to it, that if your baseline is essentially just day-to-day activities, then you've really got to knuckle down and find out, what are your risk factors? And it might be based on genetics or your familial history and that sort of stuff too. I would definitely just go and get some basic blood work done, so you can sort of try to cover just a little bit of your bases. And the things we do at Longev as well, where we actually go through the CT scans, the ultrasounds, like the calcium scores, all that sort of stuff. And if there is markers there, you've already sorted that and said, okay, we might need a cardiologist review. Perfect. That way, if they go to see the cardiologist, I've then got at least a bit of a framework or the go-ahead to say, yeah, perfect, I want them to go and exercise. Awesome. Because that way, from a physio perspective, we just don't get to see it. So you are very much in two minds about, is this person who's in their 70s and they've done nothing but be sedentary for a long period of time, am I going to be doing damage, or I might need you to go see an exercise physiologist? And then the next question is, where do you go and do that? Because you sort of need to have your heart rate monitored. We need to have blood pressure monitored. We need to have all these things done. Maybe go and get an exercise stress test that could at least give us a baseline of where you're at, to say, okay, maybe this week we're just going to start off, just go for a brisk walk for 20 minutes. So something really simple. And again, if we were to come back from a musculoskeletal perspective, people often don't know the niggles and normal aging changes. If we were to put it in like really nicely, it's degenerative changes, but it's normal. People don't know what they are until they actually start to go and train. And then they start to feel like, oh, there's a pain in my foot there that wasn't there before, or there's a pain in my Achilles or my knee. I've never had this problem before. And then it's the exercise that's to blame. That's the part that's frustrating, is that, it's been there for a long time. You actually just need to start to give it the stimulus to build it back up again. And that same comes back with the cardiovascular health. I actually personally would probably find the cardiovascular health is harder than doing the musculoskeletal stuff, because going to the gym, if you feel comfortable with it and you've got someone to guide you through it, it can be much simpler than people who are trying to go for a run again. I think we take running for granted, that think, oh yeah, I used to do that all the time. I used to play footy. I used to play all these certain things. I used to run marathons and stuff. But you go, okay, how long ago was that? Because essentially, after about 3 weeks, you can lose massive amounts of your form, function, cardiovascular function. So like from a starting perspective, you've really got to try to find where your baseline is at. I think at Longev we do that perfectly because I know exactly where I need to start.
Exactly right. And that's my big approach. Make sure you address the risk factors. You can do questionnaires. There are validated questionnaires before people exercise.
Yeah.
We get the data, exactly as you said. You get the scans, you get the imaging, and as well as pathology to see if there's any risk factors that would otherwise slow down, or you start at a lower intensity and build it up gradually in terms of the intensity.
Yeah. Oh, yeah. There was actually a study I was going to talk about today. There's 5 guys in the 1960s. I don't know if you've heard of this study. I found it recently, and they were in their 20s at the time. They forced them to go on bed rest for 3 weeks. So they couldn't go to the bathroom. They literally couldn't move. After the 3 weeks, all 5 of them had lost at least 25 to 30% of their cardiovascular capacity. If that was someone now who's been hospitalized, they're in their 60s and 70s, they've already got an extremely low cardiovascular capacity. And then within 2 to 3 weeks, they've lost almost a third of their capacity. That makes them even more likely to have all these other cardiovascular issues or not possibly come out of hospital, which is seen pretty often. When they followed up with these 5 people, because they followed up at 30 years later and then 40 years later, so when these people were in their 50s and 60s, they actually found that the 3 weeks of bed rest was about 2 to 3 times worse than 30 years of just aging. And they sort of kept a relatively good active lifestyle for that 20 to 50-year-old.
Yep.
When they followed up at 60 years old, they'd actually dropped significantly because I think they weren't quite as active. They were a bit more sedentary. So they dropped down quite a lot. They then did a training protocol, and that training protocol got them back to where they were in their 50s. But I was astounded with how much 3 weeks of bed rest can completely derail all of the benefits and everything that we need to try to do. So like you were saying, just your daily activities, like even if it's just gardening, cleaning, whatever it might be, walk up the stairs, go and get your 8 to 10,000 steps, if not more. So much of it is so important for all this sort of stuff.
Yeah. And also, if you have insults like illness, regardless of what age you are, getting back to your previous level of function before the illness is key. You can be young, you can be middle-aged, you can be older, but you always have to do some level of rehab because otherwise it's just a stepwise decline. You have insult after insult as you get older, but it's I can't see this, and it was just I used to see it in hospital quite a lot where you'd have patients that'd be sick, you have them in rehab for 2 to 4 weeks, you'd improve their strength, their cardiovascular capacity, but then you discharge them and then nothing happens then. So you get them good enough to go home, but then it's just another decline and they come back to hospital. And I know we talked about this previously of the cyclical or the frequent flyer patients who just come into hospital because they didn't have the actual environment or they didn't have the habits or behaviours of what could actually keep them out of hospital and keep them healthy and maximising their health span. Yeah.
Do you think that's changing at all? Because it is habitual. Do you think younger people now are more aware of all these other factors? Because I find the older generation, they didn't really grow up with an active strength training gym lifestyle.
I don't think so, to be honest. I still think we can do much better than what we are in terms of what we're doing in terms of improving people's exercise habits and behaviours, especially in terms of cardiovascular disease, let alone all the other behaviours that could maximise someone's or could reduce the risk of cardiovascular disease.
Yeah, I agree. If we come back to, because I wanted to come back to more of like the biomarkers and all that sort of stuff. So we were sort of talking about like your heart attacks and that sort of thing. How can what sort of things can people do to prevent them, or at least try to predict it or get ahead of time? Is there specific biomarkers? You touched on ApoB.
Still we've not talked about the exercise. You have to make sure the diet, a Mediterranean diet is key. You have to be more of a plant-based, try to have more fish than red meat, fruit, veg, a lot of more fibres. People often significantly lacking fibre intake. That's key. And then you can go into like the pros and cons of, carnivore diet versus vegan or vegetarian diets. We can touch on that a bit later, but and then sleep, making sure you get the 7 to 9 hours of sleep every night, making sure you rule out sleep apnea or other sleep conditions, managing your stress levels, especially chronic stress. So if, like, daily acute stress is important for all of us. So we have sort of the short-term burst in stress, your adrenaline goes up. What we want to prevent is that persistently elevated stress over days, weeks, months, where the cortisol stays high. That's when increase in stress, in terms of, at least from a cortisol response, you're also at increased risk of cardiovascular disease.
Is that because of higher blood pressure?
Yeah, I mean, one of it
Consistently, or
is definitely
something?
high blood pressure. Exactly right, but not just directly. The actual cortisol itself can be more prone to reducing glucose tolerance, worsening insulin resistance, and it can also lead to. And we talked about the endothelial lining, very sensitive, damage to the endothelial lining, and then we talk about the whole plaque progression. And then lastly, it's also like emotional health. I think it's underappreciated the importance of social isolation and loneliness. Those two factors are associated with worse cardiovascular outcomes. So it's really making sure that every behavior of your physical health, your emotional health is taken care of. Only once that's done, because you always get more bang for your buck there, we focus on the biomarkers. And then we get in, I mean, if you want to do that now, we have bloods, we have imaging, and then we have physical testing. So the bloods we always rely on. For me personally, we have the cholesterol bucket. So that's more apolipoprotein B. We have LDL, we have HDL, we have lipoprotein(a), which we spoke about before. In terms of the cholesterol numbers, like the apoprotein B or ApoB is a functional measure. And what I mean by that, it's actual number of particles that could be resulting in plaque formation. Whereas the LDL and HDL, LDL more associated with plaque formation, whereas HDL cholesterol is associated with removing cholesterol from the bloodstream, especially back into the liver. But that's a concentration. So it gives you a concentration of cholesterol in these particles, but not necessarily a total number of plaque-forming particles in the bloodstream. And there is a slight variability, if that makes sense, between a functional assessment and a concentration.
And so the LDL is typically classed as the bad one.
Yeah.
The HDL is typically classed as the good, because, as you're saying, it sort of helps to move it all through.
Correct.
And so does ApoB then encompass all of it?
Yeah, correct. So that includes the LDLs, the VLDLs, the IDLs, all the other plaque-forming cholesterols, rather than just LDL as a whole.
Yeah.
I mean, if the actual levels, I always have, everything I do for all of my patients and clients, I have very high expectations, and I want them to be optimal, not just normal. I want them to be in the lower risk categories. So in terms of ApoB, anywhere between 0.5 to 0.9, depending on the risk, is where I'm happy.
Okay, yeah.
LDL, I always prefer them less than 2. HDL,
Less than 2?
Greater than 1. Depending on their risk factors, absolutely. If someone has LP(a) elevated, and there's something and they're not on any medication to lower that, then that's already a predetermined risk factor that we're not going to be able to change without medications. So then I'd really want to maximize or significantly lower the LDL, because the LP(a) we won't be able to reduce that. So it's purely personalizing the context, personalizing the actual outcome of interest based on their risk factors.
Because a lot of our patients, and even for me, I don't know if it was just because it was after sickness, but when I've had blood results as well, like my LDL was in like 6.2, and then gradually got down to like into the 5s, and then again gradually, like another few months later, got down into the 4s. I'm going to probably test again in the next month or so, because I'd like to see a lot of the changes that I've had since starting with Longev. But that's pretty common with a lot of our clients, that they're at least in the 4s and 5s.
Yeah, well, definitely. Yeah. I mean, especially, and then like the 4s and 5s, probably more for total cholesterol rather than LDL.
Yeah.
So the LDL, I do see it in 4s and 5s still, but I always want that closer to 2 than double that.
Yeah.
So that's where I strive for. But for what I see with our clients, a lot of it's also things we can optimize to try to reduce that back down to the optimal range. But for me, it's having high expectations, because otherwise, if I don't, then I think I underappreciate or undersell the importance of reducing this in the first place. So that's where I strive for with a lot of our clients. If someone has no other risk factors, then I have a bit more leeway. But if considering a lot of the people, especially the age group and the risk factors that we see in a lot of our clients, I do strive quite quite. Try to lower it quite aggressively, and I'm not getting them on high dose medications. It's all about really getting the foundation sorted first with the lifestyle and what they're eating, what they're consuming, what the exercise they're doing, managing their sleep, and all the other behaviours.
Is that common in Australia? Because we hear a lot about what happens in America, which seems to be highly medicated of people who might have those elevated levels of cholesterol, LDL, and then they're getting on statins and things like that. Does that actually happen in Australia as much as what it does?
Not like in terms of prioritising the lifestyle, you mean?
Yeah, well, a lifestyle over medication.
Not as much as I'd see. I mean, it's easy if you think about the way that the health system's set up at the moment. If you have 15 minutes on the consult with a patient, how are you going to be able to touch on every lifestyle behaviour? So it's much easier to start someone on a medication, plus requires a lot of education, requires a lot of follow-up to manage all these behaviours. So it's harder to do than managing medications. And if someone does not want to start medications immediately, then it's a lot on their own accord to actually implement these changes, because they get a printout, they get a pamphlet. No one's actually supporting them with changing their behaviours to reduce their cholesterol rather than just putting them on a medication. I do think it's coming. I do think a lot of doctors are interested in this space, and like lifestyle medicine has all of a sudden become its own little society. So it's booming just because patients see it. Doctors want to do this, go back to the foundations of medicine and improving behaviours rather than just reflexively prescribing medications.
Okay, cool. Well, it's interesting to know because, as I said, a lot of what we hear is around the world.
Yeah, but I do also see where people come from, because a lot of the people that we see now is, they have elevated cholesterol for 5 to 10 years and nothing's been done.
Okay.
Because they don't have any end-stage disease, like they're seemingly young, fit, healthy, but they're just. So what I would urge on a lot of people is manage these risk factors early and aggressively, and if you're unsure, then get data to back up your what you're going to do, and we can talk about the scans and how I use the scans in a minute. But I think, in addition to just cholesterol, I mean, other markers that are key for cardiovascular health is fasting glucose, fasting insulin, and HbA1c. So the 3 monthly average of your glucose level. I want
the HbA1c.
HbA1c. Yeah, I mean, fasting insulin, I strive for less than 10. Fasting glucose less than 5.5. Fasting also HbA1c also 5.5 or less. And the reason why I strive for those optimal ranges is because especially for HbA1c, we know that every 0.1 increase, closer to 6.5 to becoming a diagnosed diabetic, increases risk. So it's not you're diabetic or you're not diabetic. It's a whole spectrum. So as you increase in the HbA1c up towards the diabetic range or the pre-diabetic range even, then you're increasing risk. And if there's something we can reduce just with modifying people's behaviours, then why don't we do that in the first place? Strive for optimal rather than just accepting mediocrity, I guess.
Yeah, which I guess a lot of people are same again. They're just coasting along. They've had all the tests, but then the doctors maybe just hasn't given... I don't know, some evidence-based like modalities that you could go and actually change these markers. So you sort of touched on the imaging there a little bit.
Yep.
What would be the imaging that you'd like to see people doing, maybe in conjunction with the blood?
That's exactly. It's key. I mean, that's definitely key. I mean, for me, a DEXA is simple. I mean, you can get a DEXA body composition scan looking at people, especially visceral adipose tissue.
Yeah, so all their fat around the organs.
That's exactly right. I mean, there's good evidence to say that you want that to be less than 100. In terms of unit centimetre square. But again, that's the evidence and that's based on a population. So for me, it's also based on their size. So if someone's smaller, petite, I'd want them at less than 75. But for males, I strive less than 90. For someone who's, 180 to or 170 to 190 centimetres, less than 90 centimetres square. But if you're smaller, male or female, less than 75. So it is a bit dependent on body size rather than just a number where I want everyone to be less than 100. And
does that have like a big correlation with heart disease?
Yeah, correct. Yeah. Your metabolic disease and thus in consequence of that, cardiovascular disease.
Okay. So DEXA, that would be the
DEXA's
first
one. I mean, I use a lot of ultrasounds we use just because it's quick, it's simple, there's no radiation, and especially ultrasounds of the carotid artery. So if you're getting other scans every 5 to 10 years or even 3 to 10 years in terms of the CT scans, you can get an ultrasound every year or two for your carotid, especially for those with known atherosclerosis or plaque formation in the arteries to monitor interval progression. So we get some more feedback quicker to not only rely on blood results, but also evidence of plaque formation at regular intervals so that we can optimize our treatment interventions. And why that's important, because ultimately you're not treating, if you see someone's blood result, you're wanting to reduce their blood result, not for the blood result per se. You're wanting to reduce it because of the risk of forming plaques, which is why imaging, directly visualizing any plaque formation is key, because it's a direct visualization of what you're actually worried about rather than just a surrogate marker, which is what the bloods are. Does that make sense?
What do you mean by a surrogate marker?
Yeah, so what I mean by, if someone has elevated, just an example, if someone has elevated cholesterol, ApoB,
Yep.
and then you do an ultrasound, as an example, but they have no plaque in their carotid arteries, just an example. You can do the coronary arteries as well in terms of the CT, but we'll just stick with the ultrasound for now. But if someone's got elevated cholesterol but no evidence of atherosclerosis, you're less concerned because you have more time to reduce that cholesterol. Or if someone's got elevated cholesterol and they've already got 30% narrowing in their artery, then you're like, okay, we need to do something now. Because then we're more worried about the cholesterol because there's direct evidence of atherosclerosis or plaque formation, which is what the imaging provides us. It provides us a direct visualization of what we're worried about, which is the plaque in the arteries.
And that's what can lead to your heart attacks.
That's exactly right.
Strokes.
Exactly right. Whereas bloods, we're just relying on risk factors that can form plaque rather than the actual plaque per se.
Okay, so the blood markers are definitely not everything.
Correct. That's exactly right. It's a good foundation for risk, but the imaging is key. I mean, in terms of, you mentioned the CT scans before, there's really two types of CT scans that we use. Is the CT coronary calcium score, which just visualizes the calcium buildup in the arteries around your coronary arteries.
It's quite a detailed image too, isn't it, that one?
The CT is, the CT is not as the CT coronary angiography, not as detailed.
Okay. Yep.
So the calcium score just directly visualizes calcium formation or deposits within the artery walls. And there's risk stratification. So it's either no calcium, so 0, 1 to 100, 101 to 400, or greater than 400. And as you go up through those risk categories, there's great evidence to show that the higher the calcium score, the higher the risk of cardiovascular events is.
Okay. Yep.
The problem with that is it's only a visualization of the calcium buildup. So calcium in atherosclerosis and plaque formation takes years to decades to build up. So it's an end stage or late stage marker of the disease is already present.
Okay.
So for someone who's young, who has lower risk factors, then a calcium score might be the first imaging you would do. The other imaging you can do is called a CT coronary angiography, which is where you use dye, and you inject dye to directly visualize the anatomy of the blood vessels or the arteries, and then you can directly visualize any narrowing, but you can also look at both soft non-calcified plaque and a calcified plaque.
Because that's pretty important part of it too, isn't it? The soft
Exactly right. Exactly right, because the soft non-calcified plaque is more likely to rupture. It's more unstable. So there's a 20% increase in chance of rupture from a soft non-calcified plaque than there is a calcified plaque. So you get more information, better detail, better risk stratification, but there's also a risk of side effects because all of a sudden you're using the contrast agent, and the side effect risk is pretty low. It's less than 1%, but compared to a calcium score that's 0, rather than just the radiation. The CTCA has radiation, but also that just less than 1% risk of something happening. And most likely it's mild reactions, but there is a chance of anaphylaxis, which can be a significant problem.
Yeah, massively. So if I'm trying to just visualize, so if we're trying to think of like the pipes of your arteries, your veins, and all that sort of stuff, the atherosclerosis would essentially be where like it's hardened, calcified plaque buildup, and then if you've got a softer plaque, maybe lodged into somewhere along there as well, is it kind of like that? It almost be that it's almost like a little balloon that's just burst. Is it the soft plaques that would burst that then causes the heart attacks or strokes and downstream issues?
Both. So both non-calcified and calcified can rupture or can expose its contents to the artery and then causing an occlusion and a heart attack. Yep. But the soft non-calcified is more at risk. So I mean, when would you do either test is usually what I often get asked. And there's more evidence for primary prevention. What that means is more evidence for using the calcium score for people who don't have cardiovascular disease as a screening tool to stratify risk. But where I get worried about that, if someone comes to me, and I do have this happen, if someone comes to me and they have got multiple risk factors, so we know that they have elevated cholesterol, they've got elevated HbA1c, they've got markers of inflammation that are up, their omega-3 is low, their lifestyle behaviors are suboptimal, plus they have family history of cardiovascular disease, but they don't want to start on medications to reduce their immediate risk. What we need to have that conversation on that day is, okay, yes, I understand you're not open to medication at this point to reduce your risk short term, but a calcium score is good at detecting calcium, but we may miss non-calcified soft plaque that could pose an increased risk of heart attack. So what we may do then is we may do a CT coronary angiography test to enable us, for a safety perspective, to rule out plaque formation, to enable this person to just pursue lifestyle behaviors for the next 6, 12, 18 months, because that gives us time.
Okay. Yeah.
If the person came then and do the CTCA and there's no plaque, great. Okay, they're at high risk, but there's no evidence of end-stage disease. So yes, I'm happy to help with them pursue lifestyle behaviors. But and then the other situation is where they then do the CTCA and it shows soft plaque or it shows significant narrowing. Then I have data to say, okay, I understand your situation and you're wanting to pursue everything from a lifestyle perspective, but this is your risk. Let's just start this medication short term just to significantly reduce risk short term, and then gradually transition into more lifestyle behaviors long term. So it's purely about having a discussion with the patient about pros and cons of both all imaging modalities you have and which one is appropriate for them to ultimately reduce their risk of heart disease and also enable them to reduce cardiovascular disease.
If we touch on more of the reducing the cardiovascular disease part, how much of a role does nutrition play with it as well?
Yeah, it's key. I mean, it's very important. And for me, it's key. And we spoke about the Mediterranean diet is key. We really want to make sure that.
Is that just because it's the most researched?
Correct. I mean, you have DASH and you have what's the other one? The DASH diet and there's another brain health one. I can't remember. It's from the Harvard University.
Not keto.
No. It's like an evidence-based one. It escapes me right now. I can provide it after this.
Yeah.
But the Mediterranean, correct. MIND diet, sorry, that came to me. So the MIND, the DASH, and the Mediterranean are the key.
Like MIND as in MIND?
MIND.
Yeah, okay. I hadn't heard of that one before.
Yeah, it's especially from a brain health perspective, but it can also help with cardiovascular disease. So which is a simple diet. I mean, it's mostly plant-based. It's good oils, lower red meat, good fibers, fruit, vegetables. But the importance, it's those things, but it's the exclusion of hyper-processed foods, saturated fats, refined carbohydrates. So it's trying to really prioritize what the body requires in order to maximize its also minimize the cardiovascular risk.
Which is pretty similar to the Mediterranean diet too, isn't it? Because it's your olive oils in nuts.
Yeah, that is
seeds.
Mediterranean diet. Yeah.
Sorry. Yeah. Okay. Yeah. If we're touching on the diet a little bit too, because I know personally, I love red meat, and saturated fat has for a long time been quite a big part of my diet, almost incidentally, because of just things like your yogurts and cheese and red meat in particular, or just essentially any meat.
Yeah.
How much of a role does the saturated fat play in cardiovascular disease?
Yeah, I mean, it's definitely associated with more saturated fat, worsening cholesterol profile. And for me, saturated fat is not an essential fatty acid. Like, you don't need to actually consume it. Your body can make its own.
Yeah, it's I guess to compare, omega-3s, we don't make it.
Correct, yeah.
Being that it is essential to consume it.
Yep.
But saturated fat, we can make our own with the foods that we consume, sort of like your olive oils and nuts and seeds. Is that's correct?
Yeah, so the omega-3s and 6s, the polyunsaturated fatty acids, and the omega-3s and 6s we can't make. Everything else our body can make.
Okay.
But in terms of consuming oils, saturated fat is suboptimal. So the more from a cardiovascular perspective, you want to minimize risk of cardiovascular disease, you'd want to reduce saturated fat, which is usually always animal fats.
I know it's the tastiest. It's the best.
It is, and it's the hardest thing to reduce, to change those behaviours. Is if it is very difficult.
It's definitely been something I've been more mindful of.
Yep.
The last few months. I definitely try to space it out a little bit more, and like we were talking about before, just eating a bit more fish, or just changing up the sources, or eating more of the omega-3s, like a lot more of the seeds and seeds and nuts and that sort of stuff, to try to get other forms. Avocado is probably a big one. I think you're a big advocate for avocado oil.
Avocado, especially for higher cooking temperatures. And then if you were having it on salads, avocado, macadamia, or olive. That's what I personally use. Because I make monounsaturated fatty acids. To go into why do I use that? So monounsaturated fatty acids, which is in those 3 oils that I mentioned. Good evidence of reducing LDL, but also increasing. So that was the avocado,
macadamia, olive, and macadamia.
Okay. So it can reduce LDL and increase HDL. So it can have, whereas other oils that are polyunsaturated can reduce LDL, but not necessarily increase HDL. So it's a matter of, if I'm using oil, I may as well use the oil that has more of a benefit versus negative. I guess you just use oil that has the most bang for your buck.
Coming towards the end of this, if people are saying, look, I'm young, I exercise, I mean, they probably might be drinking on the weekends or things like that, and they're probably thinking, yeah, I'm fine. What are the sort of things that you want to be, I guess, if someone came to you with that mindset? Yeah,
that's sense of security, like I exercise, I'm safe, or I do this, I'm safe. This is a medical condition where you do need data to back any interventions, and also back from a reassurance perspective. This is a silent disease. Without data, you really don't know where you are. So you could be doing all your right things, but because of other risk factors, whether it's genetics, then you're still at increased risk. So make sure that really you get tested to know what risk profile you're in, so that you can act aggressively early.
And that would be like possibly the scans that we were talking about.
Bloods, pathology to start off with, and then scans after that.
Like your ApoB, lipoprotein A, cholesterols.
Inflammatory markers. Exactly, and the metabolic ones,
And same thing, because quite often they do just say, look, I feel fine. Yeah, as you say, you're probably best off to go and get tested and do that sort of stuff as well.
Correct.
Is there any particular people who are at more risk?
I mean, in terms of sex differences, males often 6 to 10 years younger than females, and are more likely are more likely to have cardiovascular disease. But women, especially postmenopausal, are more likely to have later onset cardiovascular disease. And what I find really surprising is women are actually more likely to have suboptimal treatment compared to males for cardiovascular diseases. I'm not sure. It's just whether it's underreported or it's diagnosed later on. It's the statistics that show they're undertreated. And why that's important for me personally, especially and we didn't touch on this last week, but with hormone therapy for women, there's good evidence that it can reduce your risk of death by 30%, reduce your risk of cardiovascular disease by 50%, but it can also increase your risk of blood clots by 75%.
That's pretty huge. Does that come back to maybe within that 10-year time frame?
Thank you for asking, Corey. That's exactly right. There is a nuance there because these studies are based on women up to the age of 60 to 70.
Okay.
So even within women who are beyond the timing hypothesis, so the 10 years within menopause, are still likely to have a significant reduction in death and cardiovascular disease, but increased risk of clots. But the nuance, what we now know with the timing hypothesis, is women who have hormone therapy within 10 years of menopause, they're going to have a more than a 30% reduction in death, more than a 50% reduction in cardiovascular disease, and less than a 75% reduction in blood clots. I know blood clots can be fatal, especially if they go to the lungs and cause pulmonary emboli. But why this is important is for management of sex differences, you really have to be personalized, age and timing sensitive care. So a woman comes to you with significantly increased risk of cardiovascular disease, maybe that's someone you discuss the hormone therapy for, providing there's no risk of clots. But on the flip side, if someone comes to you with no risk factors of cardiovascular disease, but an increased risk of clots already, you have to be very mindful of using hormone therapy, especially in the context of cardiovascular disease.
I feel like that's a super important one because there's some massive numbers that...
Exactly. And I do think the next decade or two, we're going to start using more hormone therapy for the right women at younger ages for cardiovascular disease. but it's not in the guidelines yet just because of that risk of clots is still based on the old studies, which includes the older women. So it's artificially inflated.
So women, go and see your doctor, go and get tested.
Exactly right, especially now that they're
hormone replacement therapy.
especially with the data that shows that they're undertreated or suboptimally managed. Yeah.
Awesome. Okay. There's probably so much more that I still wanted to talk about with all this sort of stuff.
Yeah.
So I hope we got through enough of what we wanted to today. If we can summarize, so lifestyle is obviously going to play by far the biggest factor, and genetics are not always the thing to blame or use as an excuse.
Yep.
Definitely well worth going and getting personalized care.
That's exactly right.
What sort of other things did you want to just touch on with that last little bit?
I think it's a silent disease. Lifestyle, you said, on point is always the foundation, but know your data and know your risk, because only once you know the data and risk can you actually take action and thus reduce risk of cardiovascular disease.
Yeah, and that's your bloods, your biomarkers, all the imaging. Consider women considering the hormone replacement therapy. And go and see someone about, again, from a safety perspective. Go and see someone like your doctor or a physio or someone to start your baseline off. So you can start off simply and then work your way, because you touched on it quite a bit, the lifestyle factors. They can't just be done in 3 months.
It takes
they
time.
need 6, 12, 18, and then it's a lifestyle change.
Correct.
It's a non-negotiable. It's reducing risk factors as much as we possibly can so that we reduce the risk of death, essentially. I think that's what we'll finish up for there today. Thanks again for listening in. We hope you enjoyed that one. Let us know in the comments whether there's any things that you'd like to see more of, if you had any questions that we can bring into the rapid fires, or go through a whole podcast of it as well. We'd love to hear your thoughts. Thanks for that.